So this PowerPoint talks about the older adult patient and what are the nursing care. Old adult patient also we call gerontology nursing or geriatrics nursing. So here, first of all, the overview. So overview said old American are one of the fastest growing demographics. So because of technology, because of modern medicine, our life expenditure is going longer to longer. So the old person number is increasing, right? So old person care or geriatrics nursing or gerontology nursing, it is the special branches or specialized in the care of older or elderly adult. And geriatrics nursing basically address the physiological, developmental, psychological, and socio-economical, even cultural and spiritual need of an aging individual. And since aging is a normal and fundamental part of life, but in that stage, they need a special care. So during the 20s or 2010, the number of patients over 65 years has increased, with the number of very old patients who over 80 years increasing the faster rate. Critical illness in the older adult can be thought through the three parts that is determined the outcome. Predisposing factors such as fragility, also precipitating factors such as acute clinical deterioration. So this is some precipitating factor, but keep it note, we are nurses, right? So what does a nurse do for old adult? This PowerPoint actually focus on it. Or what do the old adult need? We will going to talk in this PowerPoint. So also overview continue. They said some factors is also important like delirium and polypharmacy, because old adult person can take so many medication, so it turns to error, right? So polypharmacy is important. So the problem that is seemed insignificant is younger adult, such as the memory loss or constipation, fatigue, weight loss. So all is important, right? So we have to evaluate what are the problem and then go for the solve it. So most study that shown or some of the study is very agree that the age was not a independent predictor of outcome, but multiple pre-existing comorbidities and mechanical ventilations did influence the critical care outcome. Comorbidity means the more than one or two diseases together. Patients' values and also preference should be considered in care planning. Most old adults live in non-institutional setting, including that family and friends are caregivers. And this individual should be included in caregiving and decision making. You understand this one? So most of the times the family member act as like a baby when born, and parents take care of them. So parents is the caregiver, right? So sometimes older person stay in the home care, and the nurse are the caregiver. Maybe the children's not with them. So now here we are going to focus some critical care and older adult. Critical care and unit admission prioritization framework. We're going to focus from here. So here we can say critical care unit, priority 1, priority 2, and priority 3. So also IMU care and also palliative care. So priority 1, they said the critically ill patient who require life support for organ failure or intensive monitoring they need. Therapy only provide in the critical care unit, right? And life support include invasive ventilation, continuous renal replacement therapies, also invasive hemodynamic monitoring too, direct aggressive hemodialysis intervention, then extra corporeal members oxygenations, antibiotics, intra-aortic balloon pump, and other situations require critical care. Patients with a severe hypoxemia or shock. So every patient do not need the hemodialysis, right? But some patients need if their kidney doesn't work. Priorities to patient as described above and significant lower probabilities of recovery and who would like to receive the critical care therapies, but not in cardiopulmonary resuscitation in case of cardiac arrest. So who undergo prioritization 3? Patient with organ dysfunction like kidney failure, liver failure, who require intensive monitoring and who require therapies like non-invasive ventilation. So ventilation, everybody know that, but we call non-invasive. Some kind of procedure is invasive. Some kind of procedure non-invasive means surgeon do not need to cut or anything, reconstruct or any repairment by surgical operation. We call non-invasive. Like blood pressure measurement is a non-invasive techniques. But if you need to check fasting lipid profile, you have to go in lab, then they withdraw the blood, they push the needle to collect the blood. This is the minimal invasive procedure. Or who in the clinical opinion of the triaging physician or could be managed at a lower level of care than critical care unit. So example here, post-operative patients who require close monitoring for risks of deteriorations or require intensive post-operative care. Patient with respiratory insufficiency or toileting, intermittent non-invasive ventilation. This patient may need to admitted to the critical care unit if early management is failed to prevent deterioration or there is no IMU capabilities in hospital. Next, go priority number 4 and priority number 5. This is part of palliative care. 4. Patients has described above, but lower probabilities to recovery or survival. Example, patients with underlying metastatic disease who do not want to be intubated or resuscitated. As above, if the hospital does not have IMU capabilities, this patient could be considered for critical care until the special circumstance. And priority 5, terminal or patients with no possibilities of recovery. Such patients are generally not appropriate for critical care until admission. In cases in which individuals have unequally declined critical care therapies or have processes such as the metastatic cancer with no additional chemotherapy or radiation therapy options, palliative care should be initiated for them, right? What next? So now neurological assessment of older adult. Neurological examination of older adult patient always include assessment of muscle strength, reflexes, sensation, and cranial nerves. Neurological assessment, sometimes we call neuropsychological assessment. And neurological or neuropsychological assessment in the it makes very broad, broader sense. And in common clinical practice with older adult, because of widespread use of mental status examination and also dementia related scale is important, or dementia related evaluation is important, right? So if you ask me, what are the neurological evaluation of elder person? I want to tell you is the clinical evaluation of neurological disorder in the elderly who is looking for or who requires the looks through the history or performing and age appropriated neurological problem. So it is also important to know neurological or aging patient has some cognitive impairment. So clinical evaluation is super important to evaluate the neurological disorder, particularly in the elderly patient, right? So neurological clinical assessment and diagnostic procedure we have to included when we go for assessment. And there may be changes in fine and motor skills and also hand grip strength. So there are two words. Changes occur in fine and gross motor. So example, I am going to tie up my shoe lace, tied up my shoes, or I'm going to put my shirt button. I need a fine work. But if I throw the ball, it's gross motor work. If I want to change the position of the chair or table, I need a motor muscle or gross motor in interaction, skill, and also some strength, hand grip strength, leading to decreasing ability to perform the fine motor activities. Age diminished the older adult patient's vibratory sense in the lower extremity. Reflexes are slow as a result of neuron losses. So here actually talking age-related change at the most pronounced in advanced age of 85 years or older. Even may alter the older person's response to illness, slow the great variabilities among the individuals are often impacted by genetic or long-term lifestyle factor and commonly involve a decline the function reserved with a reducing response to the stressor. So neurological deficit may alter the patient's ability to perform self-care, including ability to follow instruction and also interpret the patient's teaching. So it is important to know. What next? Next here, several standard neurological assessments are available for use in critical care. Most of these assessments can be used for critical care patients to define the patient's status, right? Example of scale that should be used routinely to critical care, particularly in care of old adult patients, include the Glasgow Coma Scale, most common we use in assessment of our neurological patient. So if you ask me about the Glasgow Coma Scale, I have a different lecture on it because it is very important how to scoring through the Glasgow Coma Scale. But here I want to tell you, Glasgow Coma Scale is a clinical scale we use to measure the person's level of consciousness, especially after a brain injury. But this scale also we use for neurological assessment in case of old adult person. And Glasgow Coma Scale basically assesses a person based on their ability to perform eye movement, speaks, or move their body. It is important to know. So I said there are three components: eye movement, verbal response, or motor response. What else? What are the other scale? One is called National Institute of Health Stroke Scale, international standard for neurological classification of spinal cord injury, and one is called Mini Cognitive Assessment Instrument for Dementia, right? So Mini Cognitive Assessment basically instruct for admin or scoring about the old patient's cognition impairment. So next go assessment of old adult in a critical care should also include consider of age-related change such as vision impairment, hearing deficit, right? Vision, hearing, particularly low-pitched or high-pitched sound, loss of taste, diminish the sense of smell. So here actually talking about the age-related changing. physical, all human beings experience change in their body, right? When they get older and older, particularly sensory change or sensory change take place. But also here, like they said, hearing loss, low vision contribute to the social withdrawal, isolation, paranoia, anxiety, depression in many old person who are impaired. Important to know. What next? Next here, neurological older critical care unit focus the multidisciplinary approach known as ABCDEF, right? So I'm talking about here is being implemented in many hospitals and especially addressed the delirium and elderly mobilizations. So delirium and elderly mobilization. What does it mean? A, B, C, D, F. A for assessment and preventing and managing the pain if patient have it. B for both spontaneous awakening and spontaneous breathing trial. Choosing lighter sedation. C for choosing. And also only when necessary. If patient has a sleeping disorder, they need some good environment, quiet environment, sleeping aid. Some elderly patient take melatonin, right? Also, we have to look after for any kind of delirium. Also, if for early mobilities, and also family engagement or empowerment is important. So most of the elderly patients, they get up very early morning, and they want to go to their toilet and they fall. So it is very important to know. So now, neurological assessment continuation. The ability to find out the risks of cognitive impairment would be useful in providing the better informations about the long-term outcome for the patients and family and allow them to make a difficult decision surrounding the critical care illness. Next here, several tools are available to assess the baseline functional and cognitive status, as this contribute to post-hospital outcome. However, incorporating these tools is challenging with many critically ill older adults as a result of inability to communicate because of endotracheal tube, because of sedation, delirium, and also critical care unit workflow, right? So cognitive assessment for old adults with critical illness to assess the activities of daily living, assessment for mobilities so that we can prevent the fall, and also cognition, because it is very common impairment of their intelligence. What next? Let me see. So age-related change in respiratory system and also pulmonary diseases. Significant age-related change affect the pulmonary system, including alter the compliance of the chest wall, strength of respiratory muscle, and also statistics, static elastic recoil of the lungs. So age-related change occur in respiratory system, basically airway function and structure increase or decrease, my friend. Or if we see, we can see what are the change take place, or we're going to talk about here, is it a change or effect of the age over the lungs or structural properties of chest wall. We will go into structural property, function of the respiratory muscle, or structure of the lungs, right? So additionally, atrial partial pressure of oxygen and respiratory sensitivity to hypoxia and hypercarbia are reduced. So I told you, structure of the lungs is impaired and patient develop senile emphysema, or function of the respiratory muscle decrease, right? Or structural properties of the chest wall alteration. As a result, old adult patients have less pulmonary preserve along with increased susceptibility to infection, or given the prevalence of lung tissues in the growing old adult populations. And it is important to understand the effect of this change to provide the optimal care. So respiratory system basically is a biological system consists of specific organ like lungs and structure uses to gas exchange, right? So the anatomical structure altered and function altered because of our aging process. What next? Next, in the picture, you can see this is the normal, and this is age-related change. So chest wall, you see it is thicker, but here we can see hypertrophied, increase the stiffness of chest wall, decrease the muscle mass. And this one, mucociliary clearance in the branches of lungs. Here we can see reduce the mucociliary clearance capabilities. Elastic fiber or cross-linked collagen. But here we can see decrease the elastic fiber and increase the cross-linked collagen. So there's the structural properties of the chest wall in change, and also function of the respiratory muscle decrease, right? And here alveolar ductures and alveoli. This is a small one we call alveoli. That is the structural unit of lungs where gas exchange occur. But here you can see enlarged alveolar ducts and alveoli. So it is permanently enlarged, right? So contractibility is reduced. So patient develops senile emphysema or increase the lung compliance and decrease the elasticities, or decrease the maximum respiratory capacities. So it is all of the age-related change. So first of all, I want to recap the airway function and structure change, like increase the airway reactivities or decrease the ciliary number and activity or diminish the airway reflexes. So if this change occur, what are the effect of the change occur? Effect, I say, like higher risks of bronchospasm. Bronchospasm require less stimuli or clearance of secretion is impaired, and also increase the physiological collapse. Like here I said, mucociliary clearance or elastic fiber, it is decrease the elastic fiber, increase the cross-linked collagen. It is a structural property of the chest wall altered. Even calcification of costal ligament occur. Thoracic vertebral height loss, also some deformity we call kyphosis develop. So when this change occur, what are the effect? Decrease the chest wall compliance or higher residual volume, higher FRC or lower vital capacity, and unchanged total lung capacity. So lastly here, alveoli duct and alveoli change occur, enlarged alveolar duct and alveoli. So functional respiratory structure and muscle altered, decrease the total muscle mass, you say, increase the stiffness and decrease the muscle mass, decrease the total muscle mass and decrease the muscle strength and decrease the proportion of fast twitching fiber. So decrease maximum inspiratory pressure, decrease FEV1 means I said FEV1 post expiratory volume decrease or decrease the maximum minute ventilation. Also fatigue develop more rapidly, exercise capacity decrease. So all occur because of aging, right? And as I told you, in clinically, it is important to know patient develop senile emphysema or degenerative elastic fiber, reduce the supportive tissue around the small airway. What next? Is there a change in cardiovascular system? So is related structural and cellular change in myocardium and peripheral vascular level have a significant effect on critically ill older client. And also cardiac and atrial system change result in reduced cardiovascular function and reserve, and also leaving an older adult at the risk for cardiac decompensation. So with aging, there are change in cardiovascular system, and which result in alter in cardiovascular physiology, means function, right? And this change in cardiovascular physiology must be differentiated from the effect of pathology, such as coronary artery disease, that occur with increasing frequency as age increases. Also, this change with age occur in everyone, but not necessarily at the same rate with the different individual, or therefore accounting for differentiate seen in some people between chronological age. It is important to know. And also I want to tell you The age-related change in cardiovascular system associated with age are decrease in elasticity and increase the stiffness of arterial wall. Let me read. So cardiac and arterial system change. I say arterial wall system change, and this result increase the afterload on left ventricle and increase the systolic blood pressure. So here, age-associated change in heart and clinical consequences. Increase the collagen and change in elastin. Increase left ventricular wall thickening and prolong availabilities of intracellular calcium. Left atrial hypertrophy increase. Susceptibility of arterial arrhythmias. Decrease the number of pacemaker cell in sinoatrial node and decrease the sensitivity of beta adrenergic receptor stimuli. So when collagen or change in elastic or increase in left ventricular wall thickening, what are the clinical consequences? Impaired passive left ventricle filling and diastolic dysfunction. Left arterial hypertrophy or susceptibility of atrial arrhythmia, decrease the number of pacemaker or decrease sensitivity of beta adrenergic receptor, all decrease the abilities to elevate heart rate, in response to exercise, also impair ability to increase the heart rate and contractility in exercise. So, what we learn from this note, as I told you, blood pressure increase, right? Because change occur cardiac system that is associated with our aging, decrease in elasticity and increase the stiffness of arterial system. And this result increase the afterload of the left ventricle, increase the systolic blood pressure, and left ventricular hypertrophy developed. And as well as other change in left ventricle wall that promote relaxations of left ventricle in diastole. And this is a drop out of atrial pacemaker cell, result in decreased intensive heart rate. And also with fibrosis of cardiac skeletal, that is calcification at the base of aortic valve and damage the his of branches bundles as it perforate the right fibrous areas, right? So all of this occur because of aging. What next? Next year, heart failure and myocardial infarction. So chronic heart failure, approximately 5.7 million people in the United States, and maybe contributing cause of death is a total number 283,000 individual per year, as a predicting cost 39 billions annually. Approximately 50% heart failure cases are found within 6% of US population older than 75. So chronic heart failure is the leading cause of hospitalizations for adults older than 65 years, with an average 1 year mortalities of 33% to 35%. Critical care nurses should recognize that older adult patients not only are more likely than young patients to experiencing a myocardial infarction, but also are more likely to die a myocardial infarction. MI is one of the most common cause of chronic heart failure that leads to the heart failure via intricate process known as left ventricular remodeling, right? So age-related change, if I make a summary, I want to tell you, increase the wall thickening and arterial stiffening, also endothelial dysfunction developed. All of this leads to the elevate the systolic blood pressure because increase the arterial load. And all of this lead to develop left ventricular hypertrophy. Also reduce the minimal heart rate and reduce the cardiac reserve, that is lead to decrease aortic capacity. In the same time, prolonged cardiac function potential impaired the myocardial relaxations. All of this lead to reduction in early diastolic filling rate. So all of this related to the aging process. Now, hypertension. The populations is aging and hypertension affect most individuals older than 65 years age. Also, pathophysiology of hypertension in old adults result from changes in arterial structure and also function, that is decrease the distensibilities of large vessels, reduce forward circulation flow, increase the pulse wave velocities, and causes the late systolic blood pressure and increase the myocardial oxygen demand, all which limit the oxygen perfusions. Older adults with poor blood pressure control have increased the risks of developmental diseases like coronary artery disease or disorder of left ventricular structure and function, aortic and peripheral arterial disease, chronic kidney disease, and ophthalmologic disorder. So, in America, if you take 100 patients who have high blood pressure, out of 100 patients, 50% patients do not take the medication for high blood pressure. Rest of 50 who take the medication, if you talk about this 50% who take the medication, out of 50% who are undertaking medication, 50% is not taking medication adequately or timely or under treatment. Out of 50% who take the medication, out 50%, but still they do not check up regularly. So all of this basically lead to heart failure, right? So hypertension managing or control is very important because it is age related, right? So basically, age-related increase the blood pressure is viewed as a universal features in human aging. So there's so many studies going on about this because age is very important factor, or age does the hypertension start is the way to explain. And I think it is called American Academy of Pediatrics and Critical Care Guideline, or CDC studies showing that 1 in 2 to 5, youth is 20 to 90 years of hypertension. So the age is related with the high blood pressure, right? Particularly. So next here, Secondary issues related to the hypertension include renal disease, obstructive sleep apnea, and primary aldosteronism and thyroid disease. Keep it note. If a patient have a high blood pressure, high blood sugar means diabetic, it lead to develop kidney failure, or kidney function impairment, and kidney function impairment lead to alter the blood pressure change, right? Or if a patient is a high blood pressure for a long time, it lead to the kidney failure. Or a kidney patient, or a patient who have a kidney problem, it lead to develop heart blood pressure. So all of the system in our body is interlinked with each other. So heart disease management, the risks stratifications tools such as the risk score can be used to predict the MI or stroke, also cardiovascular disease. Evaluation of old adult patients with known or suspected hypertension should include identification of reversible or treatable causes. Also, evaluation of oxygen damage, assessment of other risk factor, identification of that disease barriers. So recommended laboratory testing for hypertensive patients include urinalysis, right? First of all, so a simple urine analysis, we can see your kidney is functioning well or not by checking kidney function, how serum creatinine, or we see blood urea level, or if you see in urine the RBC is present, hematuria, maybe the kidney problem. If patient has a protein present in urine, maybe patient kidney doesn't work well, right? If patient has a blood sugar present in urine, means patient has a diabetes. So simple urine analysis, we can find out kidney problem. We can find out my liver is working well or not, right? So it is easy to find it out. And also serum chemistries, blood chemistry, lipid profile. Definitely lipid profile, we will check triglyceride level, we will check our TZ, we will check total cholesterol, we will check HDL, we will check LDL. So triglyceride always, it would be less than 150. Total cholesterol, our target to less than 200. And HDL is a good cholesterol, it must be more than 41 in case of female, and it more than 50 in case of men. And also our target HDL supposed to in between 50 to 150, right? So it is easy if you check blood profile and find out what is my heart condition. Blood glucose testing include hemoglobin A. So blood glucose can say your blood glucose condition, but confirmation test by hemoglobin A1C, EKG, also echocardiography can help you to evaluate all kind of heart diseases. If you evaluate the disease at very early stage, it would be easy to prevent. Treatment of cardiovascular risk factor in old adult include aggressive treatment of dyslipidemia, and lipid lowering medication. First of all, we can check how increased it is. If it is too much increase, definitely we will start medication. But so many journals agree with you, medication with lifestyle modification, diet modification, physical exercise, all together, omega-3, omega-6 can reduce the bad cholesterol or lipid extensively from the body. Also, control the blood glucose. Lifestyle modification is important. What next? And this should be considered also QOL issues such as cognitive functions, physical activities, and sexual function are reduced by aging and diseases. Treatment with medication is recommended for older adult hypertensive patients with attention to alterations in medication distributions and disposal, changing in hemostatics, cardiovascular control, and QOL factors. Lifestyle modification may be only treatment necessary for milder form of hypertension in older adult. Smoking cessation, weight reduction, increase the physical activity, and also sodium restriction result in greater benefit in older individual than in younger adult. So next pages, we can see some table about the cardiac medication considered in older client, right? So let me go one by one. We can see this is the medication and clinical considerations. First one, thiazide diuretics. It is hypertensive medication. Example, hydrochlorothiazide or chlorothiazide, bendrofluozide, and non-thiazide diuretics like indapamide and also furosemide. It is called loop diuretics, very popular medication. So first one, thiazide derivatives, hydrochlorothiazide. If you remove hydro, it should be chlor, and this is another drug, chlorhydrazone. Little bit change the ending, right? But it's the same thing. So what are the clinical consideration? The thiazide basically recommended for initial hypertensive therapy. Like this medication reduce peripheral vascular resistance, decrease intravascular volume, and all of this lead to decrease the blood pressure. Generally well tolerated in older adults and decrease cardiovascular, cerebrovascular, renal adverse outcome, and may exacerbate arrhythmias, hyperuremias if patient have any, glucose intolerance, and dyslipidemia. Let me tell you something. The mechanism of action of thiazide decrease peripheral resistance, decrease intravascular volume, and all of this lead to reduce the blood pressure. The good side of thiazide, it easily tolerated in elder adult. Like a patient came to you and patient is young, patient origin from Asia, you choose SCE inhibitor first. But if a patient came from African origin, it is good to go for calcium channel blocker. If a patient came to you systolic high blood pressure only and African, you give them calcium channel blocker. So it is important what medication you can choose for your patient with other comorbidity or other factor. Like my patient is high blood pressure and elderly patient, it is good to control by thiazide, but thiazide has also some bad effect, like decreased cardiovascular and decreased cerebrovascular and renal adverse outcome. So if your patient has a arrhythmia, it can lead to exacerbate arrhythmia. If it lead to increase the uric acid level, so hyperuricemia. So if your patient have a gout, it will be increased. Blood glucose intolerance. So if your patient are diabetic, it is important to educate your patient about the adjustment of insulin or metformin, because thiazide cause impairment of glucose intolerance, and also hyperlipidemia have a chance to develop. What about if you give the non-thiazide diuretics? It increases the blood glucose and do not increase the uric acid level, right? So it is better. Do not uric acid level, but here we can say hyperuricemia. But increase the blood glucose level like this, and can cause potassium independent prolonged QT intervals like SCE inhibitor. Also can increase the hyperkalemia or QT interval prolong. What about the furosemide? What furosemide do? Furosemide is a loop diuretics, increase blood glucose level, like increase non-thiazide, like hydrochlorothiazide or chlorothiazide, may cause headache, may cause fever or anemia, or may cause electrolyte disturbance. It is important. So we have to check electrolyte level after every certain intervals. What next? So next medication here, we can say it is called mineralocorticoid antagonist or spironolactone. Spironolactone also potassium sparing diuretics. Another one is called beta blocker metoprolol. So spironolactone, when you give the medication, it is important to educate your patient about the side effect. They can cause hyperkalemia like SCE inhibitor, or constipation, menstrual irregularities, headache, dizziness, and muscle cramping. So now what is nursing intervention or implication about it? So useful in hypertension when combined with other agents. It is one point. Can cause potassium retention or not associated with adverse metabolic effect. But it is important to educate your patient, need to monitor electrolyte because it impaired potassium level And also it is important to educate your patient to decrease the potassium intake in the diet. Next medication, it is beta blocker. Particularly here, we are going to talk about the metoprolol. Indicate for older adult patient with hypertension, CAD, and heart failure, certain arrhythmias, and migraine headache, and senile tremor. So beta blocker like metoprolol, this is a beta adrenergic blocker. We use this for management of hypertension, sometimes angina pectoris or congestive heart failure and MI prevention. So nursing intervention is important, particularly the patient who take the beta blocker. It is important to check the pulse before administration of medication, monitor blood sugar in diabetic patient, admin with food, and also taper the dose to discontinue. Also some contraindication like it can cause bronchospasm. So if patient has a asthma, it is good not to give. Or if patient has a heart block, it is good not to give. If patient has a cardiac failure, it is good not to give. Even diabetic patient can cause hypoglycemic shock or occlusive arterial diseases. Now, calcium antagonist. So calcium blocker. On the other hand, we can say calcium blocker. Calcium blocker basically we use for treatment of angina and hypertension. So there's some example like verapamil, diltiazem, nicardipine. Other drugs like nifedipine or felodipine, amlodipine, also calcium blocker. So there are some example name here: verapamil, medication name, diltiazem, and also nifedipine. So variable effect on the heart muscle, sinus nodular function, arterioventricular conduction, peripheral arteries, coronary circulation, effective in older adults, patients with hypertension due to increased arterial stiffness, decreased vascular angina, and supraventricular arrhythmia, compliance, or diastolic dysfunction, and should be avoided in patients with a heart failure. So, what are the nursing intervention if you give your patient calcium antagonist or calcium blocker? It is important to teach, report if patient have any kind of ankle edema, or avoid and educate your patient if they take this medication. It is important to avoid operating machineries, avoid grapes fruit juice, right? And the common side effect of all calcium channel blocker can cause peripheral edema or hypotension, headache, GI upset, or syncopal. What next? Next medication here. Here is hydralazine or minoxidil. Both are vasodilators. So fourth line antihypertensive medication of unfavorable side effect like tachycardia, fluid accumulation, and atrial arrhythmias when used as a part of combination regimen. Centrally acting like clonidine, centrally acting, clonidine are not the first line treatment in older adult because of sedation and bradycardia. Also, abrupt the discontinue lead to increase the blood pressure and heart rate, which may aggravate ischemia and or heart failure. This agent should not be considered in non-compliance patients, but may be used as a part of combination regimen if needed after several other agents are deployed. So vasodilator particularly relax the smooth muscle in the blood vessel. The other vasodilator commonly we use like hydralazine, nitroprusside, nitroglycerin, isosorbate mononitrate, and isosorbate dinitrate. So when we give this medication, it is important to educate your patient about the common side effect because they can cause palpitation, tachycardia, hypertension, also syncope. So what are the nursing implementation? So if your patient take the medication like nitroprusside or nitrostate, the medication need to protect from the sunlight or continue check EKG and blood pressure monitoring, or most of the nitrostate or nitroglycerin we give for sublingual use and do not swallow while. But centrally acting medication, we said here clonidine. This is alpha agonist. So not first line treatment in older adult because sedations and bradycardia or abrupt discontinuations lead to increased blood pressure and heart rate. So clonidine or methyl dopa, another most important drugs we use alpha agonist, they decrease the effect of dopamine in the blood pressure. So next go. This one is pharmacokinetics. Cardiac medication consider old adult. What about the parameters, particularly called absorption, torque distribution, metabolism, and excretion, and all of them are pharmacokinetics. So absorption, medication moves from site of administration to bloodstream affected by mode of administration. Distribution, medication is delivered from bloodstream to target tissues and affected by blood flow. And metabolic background of the medication that is rendered if active or inactive, affected by mode of administration. Excretion, remove of medication through an eliminating organ, often the kidneys. The kidney is the most common or major organ to expel out, to eliminate or excretion of the waste product. Some medication are excreted in the bile or feces, in saliva or through the lungs. So about the absorption, is there a change what occur? Decrease the absorption surface area of small gut and also gastrointestinal mobility decrease the sphincter of splenic blood flow alter, increase gastric acid pH, change in body skin and fat, decrease the lean body mass and total body water, increase total body fat, and decrease the serum albumin and decrease red blood cell, decrease liver mass and decrease medication metabolism, decrease the total liver blood flow, and decrease renal blood flow and decrease the distal renal tubular accessories function. What next? Next here, inappropriate symptom of management of medication in older adult. So next here, NSAID and non-steroidal anti-inflammatory drugs. So also we call analgesics. Example here, indomethacin, ketorolac, aspirin, naproxen. So the common used to relieve moderate to severe pain. In this case, the picture does, it does not showing here. Another medication we use, codeine, oxycodone, also reduce to reduce the use medication for the pain we call analgesic or narcotics. But here we're going to talk about the indomethacin, ketorolac, and aspirin and naproxen. So naproxen, sometimes some book wrote naproxen sodium. So naproxen or indomethacin most commonly used. Other drugs we everybody know, ibuprofen, same category. It is Motrin. If you go and you can buy over the counter, and shortly called NSAID. So NSAID has a common side effect every student is supposed to know. They can cause nausea, heartburn, headache, vertigo, oliguria, or epigastric pain, sometimes diarrhea, dizziness, or gastric or duodenal ulcer with some kind of bleeding. So naproxen, gastrointestinal bleeding occur, renal function impaired, high blood pressure, and heart failure. So if anybody take the naproxen for a long time, we can see all of this effect. So medication is a different medication, antihistamine or thus. And now indomethacin, central nervous system effect. So highest for all NSAID. And ketorolac, asymptomatic gastrointestinal condition, side effect, and aspirin, right? The most popular drugs, particularly sometimes we use it to protect our heart as well. So let me tell something about the aspirin. So aspirin, asymptomatic gastrointestinal conditions, or maybe chance to develop the bleeding from ulcerations. So aspirin also has a properties to reduce the fever, even naproxen and indomethacin too. But they have a predominantly work to reduce the pain. So common side effect of aspirin, you have a chance to GI upset, nausea. In severe allergic reaction like rash, itchy, difficulty of breathing, or tightness in the chest, swelling the mouth, face, lips, and tongue. Also back or bloody stool, confusion, diarrhea, dizziness, and drowsiness. So if after take the aspirin, in particular in the children, hearing loss or ringing in the ear or severe or persistent stomach pain, usually bruising, vomiting, it is important to inform your patient. Particularly, aspirin is not to give to the children because chance to develop Rayleigh syndrome in the children, and also respiratory alkalosis with the toxicity. So if my patient need to take aspirin, what are the nursing implementation? It is important to monitor liver function test, avoid with alcohol. Antidote is a Tylenol toxicity or aspirin toxicity is acetylcysteine. So aspirin sometimes good to take with food or meal, and also report your doctor if patient have a bleeding. Other medication, muscle relaxant, and muscle relaxant is important to know. And also tricyclic antidepressant, it is antidepressant TCA drugs, and also antihistamine. We talk a little bit about. So muscle relaxant, it is name is carbamazole, and tricyclic antidepressant, amitriptyline or amitriptyline compound. Anticholinergic effect like sedation, weakness, cognitive impairment. TCA, tricyclic antidepressant or amitriptyline, has a strong anticholinergic effect and may lead to ataxia, impaired psychomotor function, syncope, or cardiac arrhythmia, QT interval change, or may produce proteinuria or lead to the urinary incontinence, or may exacerbate chronic constipation. The cardiac dysrhythmia may produce the polyuria or lead to urinary incontinence, or may exacerbate the chronic constipation. Antihistamine like diphenhydramine, hydroxyzine, or promethazine, patients' anticholinergic properties may lead to the confusion and sedation, increase the sensitivity to the higher doses, and here benzodiazepine increase sensitivities with higher doses. So muscle relaxant, then tricyclic antidepressant or antihistamine, all of these groups have a common property, anticholinergic effect, like sedation, weakness, and cognitive impairment. So next medication here, narcotics like meperidine and morphine or hydroxymorphine, or also fentanyl. So most common name, right? Other thing is meperidine, also we call Demerol, drug's name. So all of this medication like opioid or narcotics has a common side effect like risks of dependency, nausea, vomiting, pinpoint pupil, or central nervous system depression, major side effect. So this is the side effect profile for adverse effect, especially central nervous system effect like seizure, most critical in individual with renal compromise, intense side effect profile at the higher doses, especially central nervous system effect like somnolence, respiratory depressions, and delirium. Short-acting, another medication, short-acting drugs, lorazepam, oxazepam, and alprazolam. So they short-acting less than 2 hours, lorazepam less than 3 hours, and long-acting is diazepam. This is long-acting, this is short-acting. So short-acting may produce a exacerbate depression. Smaller doses may be both effective and safer. Central nervous system effect like may cause exacerbate respiratory depression in chronic obstructive pulmonary diseases, or may produce polyuria or lead to urinary incontinence. Selective serotonin reuptake inhibitor, antidepressant like fluoxetine, citalopam, paroxetine, and sertraline. So most common selective serotonin reuptake inhibitor may produce the central nervous system stimulations, sleep disturbance, increased agitations, may exacerbate and causes the symptom of inappropriate secretion of adequate hormone, antidiuretics hormones, and hyponatremia. Now, decongestant, high level of central nervous system stimulant, which may lead to insomnia. CNS stimulant alters CNS function and lead to cognitive impairment and appetite, and also appetite suppressing effect. What next? So age-related change in kidney. So aging is associated with various and complex abnormalities of the hormones and system that are important in water homeostasis and risk factor for CKD, chronic kidney diseases. So when we are getting aging and aging, the kidney undergo age-related change and reaching fall of the functional after the age of 5 years and suffering a slow but progressive decline in its regulatory range of function is the common. So aging kidney atrophied, it has reduced the function similar to the other organ. And this is characterized by anatomic, morphologic, functional change that can seen in reduce the renal mass, renal blood flow, molecular sclerosis, tubular atrophy, and fibrointestinal hyperplasia, and meningeal cell expansion, impaired renal tubular capacities. Also, mitochondrial energy production is reduced and affecting active transport of the kidney tubules, and change in glucose reabsorption and increase the protein in urine. The number of functional nephron decrease with the age, contributing reduce the GFR, glomerular filtration rate, and also creatinine clearance ratio, and decrease the functional reserve. After age of 40, the GFR is reduced by about 8 ml per minute per 1.73 square per decade. Renal blood flow declined by about 10% per decade and approximately 300 ml per minute at the age of 90 compared with the 600 ml at the age of 40. So we can see what are the change occur. What else and what are the other change occur? Let me see. Aging is associated with the increase the various disorder and hospitalized patient and also carry and increase the risk of death. Kidney play a major role in regulate the blood water, with the dehydration representing decline in the total body water. And also dehydration can result from hyperglycemia and can be seen simultaneously with the hypo and hyponatremias. So in age-related change in the kidney basically increase the collagen deposition in this kidney and reduce the renal blood flow, and glomerular filtration rate reduce, loss of nephron and abnormal nephron structure, and it is get atrophied, older person, smaller, and increase the risks of underlying incontinence, like I said, reduce the bladder elasticity, loss of sphincter tone, and poor bladder control. So this is a risk factor to develop the incontinence as well. So dehydration can result from hyperglycemia and can seen simultaneously with hypo and hypernatremia. What else? Symptoms of dehydration in adult including thirsty, confusions, dizziness, and fatigue. Others, delirium or dementia. So dementia is a progressive or chronic. Delirium is transient. Cognitive dysfunction are common cause of dehydration in older adults, leading to agitations, hallucination, and anxiety. So if you do not treat very beginning stage, all of this leads to agitation, hallucination, and anxiety. The Dehydration Council developed and also evaluate the tools for dehydration risks with the tools is called dehydrations, diuretics, end of life, high fever, yellow urine, then dizziness, reduce the oral intake, anxiety drive, tachycardia, incontinence, oral problems, and neurological impairment. So this is the all related to dehydration. What next? Next year, hyponatremia is the most common electrolyte disorder seen in the clinical practice, and risk factor of hyponatremia. Here, three categories: increase free water intake, decrease ability to excretion water, and sodium depletions. There are three. And causes for reduce the ability to excrete water in older adults include decrease the renal diluting capacity, increase the vasopressin secretions, and or action related to idiopathic or drug-induced inflammatory primary diseases and malignancy with the SIDs, right? inappropriate antidiuretics hormones. Also central nervous system diseases. What else and what next? Next year, in older adult population who has SIADH is more common cause of hyponatremia. Hyponatremia means potassium sodium level go down. Is in older adult is associated with neurocognitive decline, gait instability, fall, osteoporosis, and bone loss, increase the bone fractures, hospital readmission rate, and also need to long-term use. So hypovolemic hyponatremia can be seen in patient with the acute heart failure. So diluted, right? Super diluted, too much water, but less solute. Sodium is less. Cirrhosis, renal impairment, and it can be excesses induced with ingestion of excess water during the excessive and weight gain. So, like another one, this presence consume the low amount of sodium and have a long-term depletion of sodium storage as well. Here, a little bit talk about the acute kidney problem, and definitely it is related to the aging. Acute kidney injuries is commonly seen in the critically care until and carry a mortality rate up to 50%. And AKI, shortly called, is defined increase in serum creatinine greater than greater than or equal to 0.3 milligram per TL. And it is in 48 hours or increased up to 1.5 times creatinine baseline 7 days, or urine output less than 0.5 ml per kg per hour for more than 6 hours. Acute kidney injuries characterized by acute damage of kidney that result alteration of acid-base balance, electrolyte abnormalities, and also increase the nitrogen product. So all is the acute condition. Comorbidities that contribute to increase the risks of AKI include hypertension. So if patient has a hypertension, it chance to develop AKI rapidly. Diabetes mellitus, heart diseases, or CKD, chronic kidney disease. Because medical procedure can induce AKI, acute kidney injury, due to lower drugs excretion capability, two of these patients and causes the iatrogenic AKI. So cause is unknown or not known. The use of contrast and also nephrotoxic drugs should be carefully considered. What next? Next here. Now, drug related. So nephrogen or nephrotoxicity induced AKI can caused by medications such as diuretics, non-steroidal anti-inflammatory agents, ASC inhibitor, and some vasodilators. GFR can calculated by formula such as modification of diet in renal diseases is called CKD EPI, which may over time that result in older adult. then contrast is not recommended for tomography or magnetic resonance imaging. If there are no contraindications, volume expansion with saline or sodium bicarbonate before and after examine may be prevent the contrast-induced AKI. Critically care nurses who are knowledgeable in the renal disease can recognize the stage of deterioration and alter the interprofessional team to patients' conditions, which may reduce the further renal injuries. So a skilled health worker can identify what are the risk factors or when the chance of attack, so it is he or she can help to prevent the acute exacerbation of chronic renal problem.